My name is Dr. Judy. I work at Emory University, and I'll be walking you through a topic that usually takes a whole semester to do, and this is Introduction to Bioinformatics and Informatics. And so the way I thought to do this is to use examples and stories and some of the projects that I've worked on to give you an introduction that allows you to have a scope of what's possible. And then if you have questions or want more resources, then we can move on from there. And so my first presentation is going to be this talk that I usually give it to the students at MIT who are doing data science for public health. And I think that, and I hope that this is helpful. I know that people don't have their cameras on for various reasons. So if you could give me a thumbs up, at least on the chat, then we can get started. Great, awesome. Okay. So hopefully you can see my screen. Like I mentioned, I am a professor here at Emory University. And the way I'm fashioning my topic, really, this module is the part for Introduction to Health Informatics and Introduction to Bioinformatics. And but I'm going to talk about it in this context of data stories across 3 pandemics. And so feel free to interrupt me, ask questions as we go along. And after we take a break, then I'll come back to really talk about my specialty, which is interventional radiology, tying in some of these concepts. So, but the big takeaway is that it's really difficult to teach you all the bioinformatics that there is. And health informatics, actually, those are 2 different sort of domains. If you think about sample size, sample biobanking, and all those things that are actually done by informaticians. And so this to me is to spark your interest, then that we can follow up with later on. So, usually it's not unusual to put these slides on disclosures. A little bit about myself is that I actually am Kenyan, and I went to school, even medical school in Kenya, in Moi University in East Africa. So this is some statement that was posted in 2001, June 7th. And this is a hearing, which is not unusual to think about in the context of sort of like some of these statements, right? These were very difficult for me to understand when I moved to the US, which is this Congress and how legislation works. And this is important for you because some of this knowledge of health informatics is really passed on from a north to south, context. But no, I can tell you, as someone who's lived in both parts of the world, no one has this right, and the opportunity, especially from an African context, is to allow us to design right and not repeat the same mistakes. And so this, in 2001, the Honorable Andrew Natsios, who was the USAID director, gave this justification to the United States Congress for why the agency, which is USAID, was opposed to giving antiretroviral therapy to Africans with HIV. And I'll read it. It said, if we had, this is the context of HIV medicines for Africa today, we could not distribute them. We could not administer the program because we do not have doctors, do not have roads, and do not have the cold chain. Africans do not know what watches and clocks are. They do not use Western means for telling time. They use the sun. These drugs have to be administered during a certain sequence of time during the day. And when you say, take it at 10, people will say, what do you mean by 10? And I'm pretty sure if people are enthusiastic, they can tell me some of these stereotypes that happen. But this work, what changed this was actually a researcher and really around data. And that's what informatics is about. And you can wear many, many, many hats. I am a radiologist, so I do imaging informatics. But you, if you're in public health, then you can do public health informatics, and you'll see quite a lot of examples of how to do that today. And if you are working in the hospital, so this morning I had to do clinic, and in that case, when you're seeing patients in the clinic, that's more clinical informatics. And if you're on the patient side, where you have to, for example, have access to the electronic medical records as a personal health record, then that's called consumer or personal informatics, and also things that happen outside the hospital. So there are many hats that are worn by informaticians, but there are big thing about health informatics or biomedical informatics is really understanding how technology and how computers are used to organize care, whether it's in the hospital, in the public health domain, or at home. And that's sort of your superpower. So this took a researcher who actually showed Africans were actually good at telling the time with the sun. And I always give this example to my grandmother, who would not be able to read a clock, but we always ate on time and would know when noon is. And yes, I'm in Kenya, and so this is very much on the equator that allows us to use the sun and your shadow. But I know that these stories can be replicated all over the continent. But the big thing is that there is a lot of power rethinking and putting these pillars of informatics that are important for you to make an impact on patient lives. As someone who works as a physician and also works in informatics, some things that you do in informatics have tremendous potential for you to impact a large number of population. Now, as you start to think about genomics, this has been very, very interesting, especially for the African genome, because people sometimes group us as one sort of group, which is not the case, one of the most diverse continents. Then you start to realm yourself into this field of bioinformatics, and that involves understanding what genomics data are, understanding biosamples, and understanding biobanking, supporting these workflows for understanding research, for drug development, for disease diagnosis, for treatment monitoring, that is the rich world of genome data. And so if that is of interest, then you should check out a project called H3 Africa. I know Kofi, who's organizing the course, is involved in that project. And that project it really tries to build capacity around bioinformatics for the continent, okay? So, if I want to move on to a little bit of a different work. I only know about this work because of a mentor of mine who did tremendous work. And the first time I would hear her, Dr. Sherry Fuller from University of Washington in Seattle, would say that these pillars of informatics, right? And that's going to be, as I talk through, something that I come back to. And so in this work, this is a project that was done to link linkage of electronic databases for the assessment of adverse effects of ART in sub-Saharan Africa. This was, actually done in Namibia in 2009. And this was to do a confirmatory assessment of the risk of anemia associated with zidovudine-based heart. And it was going to come from 3 electronic databases, and they did not share a unique identifying number. And so their work was to do this linkage. And you can see the patient population that they use, but they use 3 data sets: a pharmacy dispensing tool, an electronic medical record database, and a laboratory database. And one of them was paper-based. This was the clinical record. And so they measured the sensitivity of starting the heart regimen. And so this work is, first of all, shows some of the tasks and the scopes of a health informatician. One is this record linkage and record reconciliation. So this is in the context of research, but as an informatician who's working in the hospital, then you do have to understand these concepts of patient matching, and even more so understand what are some of the differences that exist in your own population. For example, the names in my community, which is the Kikuyu community of Kenya, are inherited. So if you took my middle name, we may share all names or just the middle name that are, it's a pattern of naming. And so that makes it, if we live in the same homestead and we don't have really a zip code or a specific address that identifies the house. If you're trying to identify patients or, say, I'm going to use GPS, for example, in mobile health to try and identify patients, then you have to understand this context of when you don't have a universal medical record ID and you have to merge these records, you have to understand the underlying patterns that make it impossible or possible. And so if you're lucky to be the informatician that is at the beginning when systems are being designed or systems are being deployed, then you sit in this era. For example, in the US, you sit in this field that you have an IT department, right? The ones that will be making sure Office is installed, Windows is installed, the computers are up to date, but then you are making the decision making of how is this system appropriate. And so as an informatician, you're not just understanding the technology, you're understanding the clinical context. In this case, this is a new system being deployed. You're going to look at how can you migrate the data, who is going to be in charge of that, and even more so that you have to understand how to get into contracts and who is going to maintain these systems. Are they going to expire? Are they going to require maintenance? Will you have to pay for them? So you also have to have a business heart. And so this is something that may be lost, especially in resource limited settings where you can be the informatician and still be the IT person, but you have to understand that these skills are something that you have to get. The reason why I like this work that I'm showing here is that it completely changed HIV care. What would happen before this work was done was that people would change. If you got anemia from zidovudine, they would change you to another ART regimen. You can imagine that if you change the antiretroviral therapy, you have increased the chances of failure because of non-compliance, because you don't know the symptoms. If you're moving to another like second line, it's expensive, right? There's a reason why some of the medications are first line. It's also a factor of cost. And it turns out that what they found was that if you just studied the anemia, it was only short-lasting for 3 months. And after 3 months, the counts would be okay. And if you supported those patients by making sure they had iron and all the support that is required for anemia, that they would turn out to be okay. So completely relying on record linkage, not really poo-pooing on when you see paper-based records, because sometimes we always think about, only computers. And that's why if you look at different circles that show the health informatics, some of them will draw not just the, so they'll draw, the circles that, sorry, it's delaying. So you sit here in the middle, you have the clinicians, you have the IT department, but in other places, it's just information records, right? They're the ones who'd be managing the paper-based systems and the clinicians, and you sit here. So you have to understand the persona, and there's no one unified way. So I went to school in Moi University. This is a university in Western Kenya, somewhere here near the lake. And it was a fantastic time to be here because there was something that was going on. And this doctor, who subsequently retired, was living in Western Kenya and was working in, global health. This is a fantastic story, nominated even for the Nobel Prize. And, was taking care of the earliest cohort of patients. And I'm trying to transition to HIV, the HIV pandemic. Remember, I said that my talk is going to use a lot of stories, and I'm going to look at the data stories across 3 pandemics. So, so Joe was working, and the first time, and this is in the when I was a medical student, is we had a lot of patients who were dying from HIV/AIDS, and so he is lucky. And what was happening in Eldoret then was that we started off with an Excel database, and the Excel database. What happened with it is that it may be impossible for people to understand today, but we would have, it would have like a maximum number of rows that you could fill in, right? And if you marks those roles, but because when you're in a pandemic, this is not unusual now as we've gone through COVID pandemic, then you need to make sure that you can add more records. And so when that couldn't sustain the clinics, we moved to an access records, but these were hampered because there were limited number of records. And when you take care of multiple sites, remember I just talked about the record linkage, proper patient identification, which is the role of an informatician. And when you have a rapidly growing number of patients, then it's very, very difficult to understand how to take care of this. And so I was lucky to be seeing this transition that was happening. And this has also informs my passion thanks, Kevin, when around combining being a physician and also being an informatician. And I've always wondered, and this was some of the early questions, they were wondering, well, who was dying, right? Who was taking the medication? When were we running out of stock? Who was losing weight? What was their support system? And I'll show you some of the innovations and refer to them in the context of health informatics, what they mean. And I found that I ended up loving to work in these two fields where I combined the love for technology and medicine. And I'm always focused on trying to see how to improve patients' experience using technology. So around this problem, there was Buck, who's here. Buck is Joe Mamlin's son, who I showed you, who was taking care of patients in Western Kenya. And Hamish Fresher did quite a lot of work in Rwanda with Partners in Health, and Paul Beyondage. And what they were discussing here through one of the meetings, so there are societies that support you. If you're going to be an informatician, you have to look them up. There are quite a number of resources here. One of them is called EMIA. If you're in the US, there's FEMIA, and there are some societies, even local within for the African context, like Helena. And so those are the societies that people who work in this field get together. And if you're going to have lifelong learning, then this is important. And when they were having, their break during the EMIA meeting, they said, we're really struggling with care in Africa. And, Joe was telling Buck, who's also not just a geek, but also a physician, hey, I'm really struggling with patient care. And this started to become the birth of one of the largest open source medical records used in the world, called OpenMRS. How many in the audience know actually of this system?
No.
Yeah. Nobody? Okay. So OpenMRS.
I know about OpenMRS.
You know OpenMRS? Do you build it? Like, have you used it? What's been your experience?
Okay, we use it to actually monitor, because when I worked with an NGO for some months, when I was in my final year in school, I volunteered for an NGO, so they use it to track HIV cases. And so I typically was just a data entry officer, so I worked with it, entered data on data. So it's a good platform.
Okay.
It's an EMR, yeah.
So this is like an EMR is the domain, medical records, right? Managing healthcare records within the hospital is one of the skills of an informatician. And so I was in this site, right? So the first OpenMRS site was in February. This was when I was in medical school, and then coming back in Rwanda and then in South Africa. There are a few things that have happened, right? Some of these systems have been overhauled, and I'm going to talk about some of those lessons because these are things that you should take away. And it provides quite a lot of lessons to understand how to train the next generation, or, not just because you're young, but also because you're going to make an impact in the next evolution of these systems. And so this is, has taken care of quite a lot of patients around the world. And the reason why I'm showing you this is that you have to separate yourself from just the technology, because sometimes if it doesn't work, and we need to really encourage people to share their lessons that are learned, and I will be sharing some of the things that I have made mistakes, and so that I hope that that's going to be an inspiration for you. So if you've never seen what this EMR is, electronic medical record system, it's easy to just go to this site, and we will have like a quick demonstration of what some of the concepts I talked about are. So this system has been very successful. This is like a track up to 2021. You can see there are almost, 15 million patients who've been followed all over the world. And what happens is that, you know, and we did quite a lot of studying around this, and I'll show you this about how to build systems, but we've taken a little bit of what's bad and put it back there. So you have many, many things. You have Muzima, which is a mobile thing. You have, this is a Bamni, which, you know, another flavor. There's Kenya EMR, Open SRP, Open HMIS, all these DHIS too. Do people know some of these other systems? And so, you know, and all these are trying to collect the data. So you as an informatician, at least in health informatics, you may interact with some of these things, and even more so that you may even interact with sort of privately developed systems, but the principles still remain the same. So the first lesson that I learned, this is available in the public domain, so I'm not trying to embarrass anyone, is, you know, Doreen posted this on her profile, you know, saying she's been HIV positive since 1992, and very, very strong outreach and advocate. And I mean, it's really amazing if you think about how many patients died really early from this disease. And so the reason why I show you is that the first time I started to take care of patients, and this is not unusual, they had this yellow card, you know, and this yellow card was very, very important, because if you had it, then you had AIDS or STD. You didn't need to know anything. If you saw me, you know, other people had blue cards, other people, you know, but if you saw me with a yellow card, you know that I have this diagnosis. And the second thing is that it's the medical record number that was registered. Most of those early registrations would have, like, you know, lab 00, and they would have CCC something something. And so the medical record number, patient registration, and understanding how to proper register patient and what are the standards for that, apart from the problem that I talk about, patient matching and the similarity of names, it's really some of these stigma that are important as an informatician to consider from the first instance. And this is important because if you label people with their disease, so for example, COVID 2, 3, 4, then you can really stigmatize them. And we would make this mistake again later on when we would come back to, and this is not necessarily a mistake of an electronic medical record system, it's really an information gathering error. But you as an informatician, as you think about implementation of system, you have to have clarity around how to, you know, register and to make sure that you're not perpetuating some of these biases into your medical record system. And so we would repeat the same mistake when we started to print decision support things. And what this would happen is that we were expecting Judy to come to the clinic, and Judy has not had a chest x-ray. So tuberculosis is one of the earliest killers for HIV patients. And you would expect that I would have a chest x-ray in the meantime. But it turns out that when you ordered the chest x-ray, or, you know, you're not deploying this system in a live way that you can just interact with it, you know, there's quite a lot of systems that require you to have an electronic medical record system, a paper chart, and then re-enter the data. So double data entry. And that can have a big problem and big errors, and that's your role to fix and investigate those errors. But if you now are required to communicate to the doctors who don't have a live system about how their decision support is going to be, then you put them on paper based. And once you put them on papers, what happened was we would print these pink sheets. But remember, HIV is not just a disease for you. There's discordance couples and non-discordance couples. And so if you're going home with a yellow book or a pink sheet of paper, once people understand, oh, this means that you have a disease, then you can get a lot of burden and a lot of stigma. And so as an informatician, rethinking how care is done and how you can ensure best practices. And those best practices are not just because they're very local context is one of your tasks. So for example, here in the US, we do not have a universal medical record identifier. And the way we identify people is using a social security number. It's not really it's more of a financial benefits type of registration and work eligibility. I know that in Kenya right now, your mobile phone is almost moving to be, your mobile number is almost moving to be your own identifier, just given how much registration is done, how much banking is now being done on it, and how much it's linked to the financial system in terms of even being paid. And so as you start to gather this information, you have to think about privacy, security, and that you factor in context that is important based on where you are. Okay. So I talked about the Kenyan examples. One of the earliest things that we looked at was, you would send reminders, right? So not just registration, but you'd send reminders to the patients using their mobile phones. Again, when you're dealing with a sensitive disease, right? Remember, this has very, very much changed with the digital, leapfrogging in Africa for mobile access. But most of the time, you'd find initially that they used to have a head of the household who was responsible for the mobile phone. And if you looked at them, then if you send me a reminder about my HIV, and maybe my husband doesn't know that I'm even HIV positive, then it's really difficult and can cause you're not sure about who's in the intention for decision support. I talked about the pink sheets, and now I'm talking about mobile phone. One of the domains of health informatics is this clinical decision support. And this is important because you have to decide what alerts to send, and this can cause a lot of alert fatigue where people don't want SMSs all the time. You can imagine if you're in a WhatsApp group where people send spam all the time, you have to mute them. And it happens the same way in this electronic medical record system. But the role of an informatician is then to go on the back end and build these rules for decision support. And those require for you to either work with the provider, the healthcare provider who is building the rules, or understanding a national practice guideline that is important for you to build a rule that makes sense. So for example, I gave you the example that tuberculosis is one of the biggest killers for HIV patients in the first 3 months in the acute HIV phase. So most of those you want to make sure you're screening, symptom screening, chest x-ray, if they have sputum, doing a sputum test. And if you want to make sure that you have that compliant, then that's what you do in the first place. If you're in maternal and child care, antenatal care visits, and what you want them to be done. For example, do you want to make sure that there's a birth plan, that every mother has a blood pressure recorded, they have at least one complete blood count done so that you're not surprised with anemia, those type of rules. And they, in our world, sometimes the systems used do not allow you to do that. Then you need to have rules, and you have to maintain them. And so clinical decision support remains a big, big role for a health informatician to navigate around. So I talked that you have to have clinical decision support. Let's say you wanted to say every mom who comes must have a blood pressure recorded, right? So if you just look at the people who are attending this class today, there are many, many languages, many topics. And we, even in Kenya, I speak almost 4 different languages, but the language of medicine is so important. And I will show you an example of this, the language of radiology, and it's managed by health terminologies. And so if you look at health terminologies, then this can be context specific. I'm showing this because this is a good place to get started. If you just want to say, hey, Luke, could you go and help me transform my paper-based system to an electronic medical record system, which is the role of an informatician and health informatics. And you have to say, well, maybe if you're a doctor, you kind of have to still see what does the world refer to something. And especially now, when we started here, people wanted to figure out, okay, how is mom going to come to the hospital to deliver? Is she going to come on a bicycle? And should we be thinking around if you wanted to make an intervention, for example, to say all mothers will get an Uber voucher to come to the hospital when they're in labor to improve hospital-based delivery, then you would have to make sure that when people record one value, that it means the same way. So this is the power of terminologies. And I will show you briefly around this and what you should be looking at. But the open concept lab is an interface terminology. And what that means is that you have reference and interface terminology, but interface is what is facing you. This is what you're going to look at. So for example, if we take so if you come here and say cough, okay, then in your medical record system, you can see that these are many ways you can represent cough. And so learning just about terminologies takes like almost a semester again. And you can see that there are many types of codes, right? You can have, so let's pick one, and you can see in this case who uses it and where it's being used, right? And is this a symptom? Is it a diagnosis? Is it just you know, an order? And so if you look at this, you can see that this is a name. You can see that this is recording just someone who has a cough, and you can see in what sites it's used. And I just want to show you some of the terminology sources. So you can have, for example, some mappings for example, a WHO, you know, so an ICD code, right? And if you have procedures, then you can have them mapped. In the US, you have something proprietary, which is the CPT codes that are owned by the American Medical Association. So you cannot really use those, but you can either tag a diagnosis with an ICD code. There is also something called SNOMED, and SNOMED is just supposed to be a broad-based terminology place. So if you go to SNOMED here, there you have to pay for it, but there is an international version, so you have to understand if you can use the terminology. And here you can now put in your cough, and you can see that there are many types of cough that you can write. And when you come in here, you can see that this is a finding, and you have to always say differentiate between what the doctor found and what the patient complained about, because as you can imagine, your downstream effect of how you collect your data is important. And so there are this sort of, you know, you have this concept of a parent, and you have a concept of a child of who can be included in that. So, right, for example, early morning cough is a child of cough, you know, that's still a type. You can imagine that as a type of cough, or a nocturnal cough, or cough when you're laying flat. So anything that you have to do here. But you can imagine if you have a cough, then maybe your diagnosis ends up being tuberculosis, and you can see that this now becomes an order. But if you had to use all these terms, it would be too difficult for you. And you can see that the children here are even looking at disseminated tuberculosis or HIV associated with tuberculosis. So for the not just the doctors or the nurses or the, you know, anyone who takes care of patients, this makes sense, you know, organ-specific tuberculosis. So the way you tie all those things together is to get an interface terminology. And an interface terminology, if you go back to, like, this is the CL dictionary, and you look for the tuberculosis, then you can see, for example, here, this is just asking, will this patient screen for tuberculosis? And that's a yes or no. And that's not exactly a diagnosis if you think about that. Or you can say that tuberculosis, you know, for example, this is linked to the WHO, and you can find that this is part of the guidelines. So ICD codes, SNOMED, LOINC, CPT codes, and all these are usually tied because you can't keep picking one versus another. LOINC refers to the lab codes. If you're just going to report a lab test or a lab finding, in radiology, we have RADLEX. So there are many types of codes and terminologies, and those are important, and they're tied together by what is called an interface terminology, which is what you deploy in your system. The biggest mistake that people have today is that the technologies and the systems that they deploy are not backed by any terminology. And so this is that world that I was showing that you may live in, where you can be a provider, you can have the IT people, and then you, with your health informatics training, who understands patient registration and patient linkage, how to do contracting for electronic medical record systems. You're part of a society that educates you about what the role of an informatician is. You can build clinical decision support for your patients and build reports, but also that you understand healthcare terminologies. And I'm happy to go into details about this, if we have time today, but I wanted to introduce this concept of health terminologies because it's the most important blind spot that we have, especially understanding what's paid for, what's in the front end for you as you use this. And if you have to work with two different systems, then how do those work with each other? And if you're in charge of a system, or you're working with a system, or the first three questions when you have to go to a new organization and have to do your job as a health informatician is you should try to figure out where is your dictionary. They may not really know that it's a terminology, because you're not going to be able to do anything. And in public health, you cannot do massive reporting unless you're backed up by a terminology. Okay. So I'd say that we talked to a lot of users, and the reason for some of the chaos really, and this is just a random fact, is I interviewed almost 100 people who had worked with OpenMRS from this era. It's amazing that you can have a system built by volunteers. And it turns out that the initial path, you have a lot of code contributions, but you can only build so many things, right? So you tend to have, maintenance code here. You're not really developing new things. And what ends up now moving on is the community and growth of the maturity of the product. I showed this just because if you don't manage like the stakeholder interests, it's how you end up managing 50 systems like I showed here. And now you're managing something that is trying to make sure that the hospital gets paid, and another thing that is trying to make sure that you're tracking your supplies, because all those things are, you're the choir master trying to control all those things, but you have to understand how they work with each other. And so in most of these places, when you have nothing, it may be just improving the registration is what you can do to make sure that all these downstream applications work and are appropriate. And I will be I talked about terminology standards, but there are other standards around data models and also the data sharing, which are important. So I talked about my lessons from HIV and how those have been influenced by informatics. And now I'm going to talk about this project Buende, which is transitioning to the Ebola pandemic. Now, if you're in a crisis, right, you have paper records. I think these are familiar to people. And you need to be able to extract data, right? People are saying, how many people are dying? How many COVID tests should I send to you? What's the rate of positivity, right? Public health, right? You are working at the interface. So my project, when I was a student at the Regenstrief Institute, was to work with the public health department and to work on a notifiable condition detector. And this is because the US rules say, look, if you have tuberculosis, if you have syphilis, if you have gonorrhea, if you have HIV, then we do have to disclose the people you don't have to say that Judy is sick, but the people around you must understand that they need to get screening. This is a public health initiative, right? And you can imagine that it's also happened for example, patients who have multi-drug resistant tuberculosis in the community, where they have to come to the hospital every day and get their medication. So, people can see how this can work. But if you have paper, how are you going to extract this paper and be safe? And so this was the inspiration for the project Buende, which was shut down. But what they ended up doing was to develop something that was going to be portable, easy to analyze, easy to back up, easy to access historical data, and allow you to make decision support. And you can see that this is in French, and you can imagine some people will not be able to understand French. They required to show graphs. And the way they did this was by using a spreadsheet. And all they did was to extract this concept, mapped to a terminology, the CL dictionary, which has almost 16 translations for different languages, and it's already structured. And once they cleaned up their concepts, all you needed to do was have this massive spreadsheet, and then someone went back and wrote an engine that would convert that spreadsheet into this form that would allow data to be collected. We are living in an era of ChatGPT. I hope some of you have heard of this amazing technology that is coming. It's going to make it really easy for people who don't even have to have programming experience. So you, as an informatician, you don't need to know that. And if you where you can provide your Excel spreadsheet and have an app developed in just minutes. And now you can deploy that app on Android phones or just a web browser, really transforming just how much easy it is to develop systems. And it's going to, again, require your pillars that I keep repeating. Who are you registering? How will you resolve duplicate patients and merge them and reconcile them, because so that people can see one record? How will you think about decision support? What terminologies are you going to use, and how will you share with people you have to collaborate with? And then the technical portions for making sure there's internet and all those things. If you're lucky in a place with a lot of resources, then those are done by the IT department. So that was one innovation. The second one they did was that they deployed this on these Intel Edisons, which would be the servers. And so very, very small, lightweight server. And this could be charged with, if you have a portable power bank or you have the USB on a truck, if you're going to a place without electricity, it could be charged. And so this, I briefly mentioned it earlier, where you don't have same time data entry, because sometimes you have this double data entry. You write your things on the form, then it's transcribed, or sometimes you enter the data, but it's not synchronized. So a lot of mobile health systems are developed this way, that they're not synchronized till the person goes back to where there's internet. Those reconciliations and those tracking are the role of an informatician, to make sure that things don't break and data are not lost, and that data remains useful and maintained for utility, whether it's for public health or for the patient or for lab or wherever you're doing. And so the other innovation that they did was to wrap this into this casing that you could just dip in a chloride bucket when you got off from the hot tents and come out, and you'd be able to enter data with it when you have gloves, right? Because you have PPE, and so you cannot go to this tent and be there and fumbling and trying to remove your hand so that you can write on the tablet, and that you would be able to see when you are in a dimly lit room and be able to sanitize the device immediately you got out of the room. So that spectrum showing you just how data management was, I hope reemphasizes what are some of the skills for an informatician. So this is taken outside Kibera slums in Kenya. I like this because I'm transitioning to COVID, but also because I'm trying to show you, even without understanding the language, you can see that you need to wear masks, you need to wash your hands, and you need to socially distance. And again, hygiene, because you have coronavirus. So I loved this vision of art that was there. And this was made very earlier on, something impossible to think about, that we would have PPE shortage, we would not know what's the utility of testing, what resources were being utilized, also just worry about working with a new disease, changing workflows. And, those were the problems, but most of my family still lives in Kenya. And and the reason why I'm transitioning to this is that, there are many, many things, and I'll just briefly show this, which is, could AI and imaging help solve COVID? So the reason I'm not giving an answer to that, the answer is actually no, but it's really to say that there will be new technologies that come to you as an informatician. And so this concept of deployment and how they integrate in the enterprise, who monitors them. So we find different roles for informaticians, including a chief information officer, and so they have these titles a lot in the US, which may not really translate locally, but when you have new technologies, especially the future informatician will have to be one, not necessarily building AI, but is one who brings AI and makes sure that it's safely used for the patients in their institutions. This is just an example showing where the artificial, so I do a lot of work around this, And it was just showing that the AI are not very good at telling pneumonia. We knew this, but they're also not very good at telling COVID, detecting COVID. And it usually relies by, fitting onto the images that are learning where the X-ray was acquired, because we usually put these labels. They're usually different based on the type of imaging that you use, and that's how it learns where to look at it. And it's not really detecting pneumonia; it's learning where the image is from. But more important for you is that we really don't know how many people died from COVID, right? And so very few people in very few countries in Africa, actually only 8, record more than 75% of the death. This is according to the United Nations. But we saw quite a lot of interesting innovations that come up with understanding proxies. And this is, again, the role of, especially if you think about public health informatics. And what we saw, one was verbal autopsies. And this is just saying, hey, I'm going to, so like in Kenya, we have this thing called Nyumba Kumi, and the people in that neighborhood, that 10 households should know each other. And so if they haven't seen Judy or Judy died, then the head of that unit should report. And so there are these informal ways of trying to estimate the disease burden in the community. People also paid, they paid for the dead, sort of like burial expenses if you disclosed why they died. Now you can obviously see why that could be a problem. If I don't have enough money, I could say, well, he died from COVID if I need the money. People also looked at Facebook to see the death notifications or like rest in peace, to try and mine that data to get a sense of the deaths. And also with satellite imagery, right? So bringing new ways of understanding data, people started to look at where they could see, burial sites, especially some of the satellite images are very pristine. Now, in my community, you're buried on your farm, so that may be a little more difficult. And also remember that not everyone buries their dead. Some people burn, cremate their dead, and so you may miss those numbers. But most of the innovations that came from here were to incentivize data collection by people who are either in the funeral homes or in the mortuary to try and get more data. And so when you sort of think about how do you manage pandemics with health informatics, you can use analytics in sort of like the hospital care system. You can look at telehealth and remote monitoring. And this was important for people in the US, but we do know mobile phones, they have a big penetration. And so thinking about mobile health and how it's used is your role as an informatician, looking at electronic health record system and administrative systems to manage just the internal hospitals, like I mentioned, supplies, the other things that need to run, reporting requirements, right? So DHIS has been one of the systems that is used a lot to report to district health officers and subsequently to the government and to the funding agencies, and also to visualize some of the, to support public health in terms of surveillance, okay? And so this, again, I told you, this was just outside my home village, again, showing the same, images around Corona. And so I want to transition to another portion of my talk, but are there any questions so far? Which will also allow me to get like a break. Questions, comments? Did you learn anything at least? Or is it just too late and everyone wants to?
Yes, of course.
Okay, thanks. So if you, I want to quickly, I mentioned some of the terminologies that are existing in terms of, capturing data. The other thing that is interesting here is around allowing people to analyze data across different institutions. And this is the only way we're gonna save people's lives. And it also gives you a sense of your data quality. This remains a big issue and is a role of an informatician. And so there's this community called Odyssey. It's an open source community. So you do really need to check it out. They have free training. Don't worry, don't get any benefit if you do this. But what they teach you really is also how to combine now terminologies and then a standardized data model called OMOP that allows you to even just show your data how it looks, even without further analysis. So like in this case, you can see what's the number of patients. This is the year of birth. You can see sort of like, no, this is actually the number of patients seen in the facility. You can see, like in 2020, there's quite the highest peak that allow you to look at places. And there is quite a lot of sensitivity, which is why you have to do a lot of local contextualization when it comes to health informatics. Now, when you read any book for health informatics here in the US, it starts off by saying, look, Obama is the one who stimulated this medical record system. And he did this by making sure every hospital that moved from paper to medical record system got paid. And so then people started deploying medical record systems. So it's not very old if you think about when Obama was president. And after that, people started to get incentives to try and say, if you use this to improve patient care, allow your patients to get access to their record, or use clinical decision support. And that, if you have to sit an exam in sort of any of the developed world, they will ask you those type of questions, is because the incentives, the government really puts stimulus for making sure that you have meaningful use of information, but also that you have not just meaningful use, but also the incentives to make sure that you maintain patient privacy. And this is important, especially as we work with genomics data for us, because when I have my genome, you understand the genome of my ancestors, my parents, and also my children. And so, I may be okay, but if you have, let's say, a familial deadly inherited disease, then you can see how that is perpetuated and why you have to think about these things in terms of privacy. And also some of the things that we're going to struggle with is like who can access the data. And so understanding Odyssey is a community that allows you to come to a standardized data model that allows you to understand your data problems, but also improve the amount of data that is shared to people around your community and your facility that need to be used, but in an anonymized way that they can build cohorts and run analysis without breach of privacy. So this is a very important result for it. So you can see, like if you had different facilities, this is year of birth, and you can see sort of like how old the patients are. So the African patients tend to be very young. I kept mentioning about genomics. This is a really good paper. Segun does quite a lot of work on genomics on the continent, and there is a lot of investment and effort. For example, these are centers that do a lot of genomics work. So if you look at H3 Africa, doing amazing work, and you can see who's trying to look at, for example, diabetes mellitus, or and not just in genomes in terms of health, but also in terms of, so genomic data tends to be very, very heavy to understand. And so what's happening is that informaticians now have to learn about cloud computing as a skill, which was not there when I was in training, because you cannot run some of these workflows, for example, imaging and this cloud computing, genomics without cloud computing. And so understanding the workflows and how to support your people to do that, how to reuse data to be efficient, is becoming a little bit in the realm of bioinformatics, and also managing samples, because if you have to keep running genomic analysis on them, or you have people who are growing stem cells, and all those modifications, then you do need to understand the management of the samples and how they're linked and how they're shared as one of the domains. And so if you look at this H3 Africa, Human Heredity and Health in Africa, provides quite a lot of resources and training if that's the pathway that you want to go. And I want to sort of transition here before I quickly go through my imaging one, is that there are quite some challenges around data sharing that you have to understand. And I did feel bad, but, Dr. Moodley, Professor Moodley has done quite a lot of work in this. And that's amazing work. And what they sort of show that there's quite a lot of data colonialism, right? A lot of data leaving the continent, or, people exporting data that is used to make decisions. For example, the Omicron genome sequencing, which was done in Africa, but by the time I'd even gone back to visit my parents, they hadn't received the booster with the that could cover the Omicron variant. And so this understanding of benefit are not just the traditional ways we've taught informaticians, but you have to think about sort of like this ethics and understanding how your own institution, not only, remember, you may not necessarily be a researcher, you're just the choir master, but you have to make sure that the IRBs are making that the judicious use and governance around data systems, and you may need to understand and explore what those roles are. This is a really good book for public health. I encourage you to read it if you can get it. It talks about politics, right? So I talked initially that you have to have business skills, but, understanding contracts, maintaining contracts, right? And you may not be the expert, but you may have lawyers who can help you with this. But if you don't put milestones for your project deployment, then you also have to understand politics. And, especially in this disease where we saw people saying, don't test, at least in the US, and understanding some of the implications of that. And so it really talks about how organizations can be paralyzed. And I recommend this book for all my informatics students, because it allows you to understand as some of the, like in Kenya now, we have governors in every, county, and they run the hospital system, and some of them are in the national government, and some of those interactions and who can you report to, what can you report to, especially if it's a negative result, are really the superpowers and political knowledge that is required for health informaticians. So I'm going to stop there and stop sharing my screen and take some questions, and then I will quickly go through imaging informatics.
So well, what I'm getting here is the need to actually gather, collect information, and is particularly quite interesting with the genomics aspect, where a lot of data can be generated, and you need to place it on the cloud. I don't know, it comes then with issues to do with security on the cloud, among other issues. Anonymization of data is one aspect that I've also picked from what you're saying, and how you would then get to relate some of these things. So if I get this correct, when you deal with the health informatics, really you are looking at patient level data. Can we do that with institution level information that is aggregated?
Yes, that's a great question. And so when you are an informatician, you have many, many hats. You cannot do all of them. You have to decide which one you have to take off, okay? And so in the clinical workflow, then you're a clinical informatician. You're thinking about day-to-day, when patients say, I want my CD for my images, right? Or they get imaged in a village and now they have to go to the national hospital and they need data access, right? So you're managing that type of health data access for them, right? You're putting the pillars. Now, I did put a caveat that you may be the only person. So you're doing the IT part and you're doing the informatics part. But other ways that you can be an informatician are, for example, in the public health informatics, right? So that point, you're looking at the hospital data, and you're looking at maybe interfacing with a local CDC organization, or you're looking at interfacing with the local public health department. And so in that place, you're interested in more of the aggregate data reporting. And so thinking through, for example, COVID, and what would be your role for that, and how you have to report and support reporting to different places, then that would be sort of like the role that you do there. Other people are more in consumer informatics. So a lot of people now are wearing smartwatches, they're wearing, they have home tests. If you go to like some of the things that are coming down the pipeline for, in the developed world, people are putting sensors in their toilets to be able to see when they pee, if they see anything different. And so, so that's a different role. There's really no like research informatician. That is just a role that tends to be supported by everyone. But the domains of imaging informatics, public health informatics, laboratory informatics, pharmacy, some of them under subsets of clinical informatics, mobile telemedicine and telehealth are different domains that you can wear your hat on. What you have to focus on is understanding the pillars of the informatics, things like clinical decision support, health terminologies, data sharing and governance, patient registration, patient reconciliation, patient matching. And now, as we move to cloud computing workflows, what allows you to wear these hats and interchangeably become a public health informatician, and also the business and the politics around this allows you to be able to move to different domains. Did I answer your question, Blessing?
Yeah, definitely. I think yeah, you did. Thank you so much.
Mm-hmm. Any other reactions? Yes.
Yeah, thank you for that presentation. I found it particularly interesting when you spoke about hospitals being, I guess, incentivized or paid for, participating in digitizing their medical records. And I was thinking around that, and I was wondering, how could such a project be like upscaled and probably be sustainable for other small territories that may want to adopt, in terms of funders, because more than likely that our government probably would be able to do that. So I was wondering if you had any ideas or suggestions.
So one thing that is happening now is people have realized that the funders are realizing. So first of all, you're correct. Like in the US, the person who pays for healthcare is not really like donated money, but quite a lot of countries in Africa have some portion of it that is donated money. And so what's happening is that the funders are realizing, if you look at 10 years of funding, that sometimes you just have a big burden for reporting, and the information is not scalable. So if you think about what people are envisioning now is to say, look, I want to go back and fund people to build infrastructure. So for example, there is a health information exchange. I'm not so sure about the adoption for that. And there's one thing that I didn't discuss in my talk, where funders were very, very focused on one thing. So for example, the OpenMRS was built initially for patients with HIV. And if you got a pregnant patient, what they would do is that they would get the record would be in the OpenMRS through pregnancy. And if your like the ANC had worked, right, they would have a normal negative baby, but that record would be on their paper chart. So this living in two worlds, one is in the digital record and one not in the digital record, was a mistake. And it's really driven by funders. And because then you didn't know, was your treatment effective? And who's going, as a doctor, are you going to write, you enter things in the notes and then you enter some things in the digital record? So bringing quite a lot of complexity around that. And so that is one of the limitations. So I would say that there is quite a lot of sentiment around changing this, but also because AI is coming and people want to apply artificial intelligence, the reason why you cannot scale about this in the African context is really because of is because their records are not well organized. Else, that's why you're seeing quite a lot of work being put on in the US to do this. And so those are some of the bigger society factors that may bring some resources to local organizations to strengthen their health systems. There is some initiative, I think there's like the Digital Goods Initiative and a path that tries to bring some best standards. I want to be careful that you do not think that you can start from scratch. You're going to make a mistake. You should leverage the success of what other people have done and leave the things that haven't worked to make sure that what you deploy or what you supervise is successful for your local context.
Thank you. Just wanted to add that this discussion is particularly interesting to me because I just finished work on a COVID-19 study. I'm from Jamaica, and a part of it was looking at metabolic data. And we decided to look at the lab data, which we believe would have been recorded on file electronically. And actually doing the study, we realized, as you said, a lot of the data was in the labs or on file, and it was just, not organized well. So an initiative like this would be definitely integral, but thank you for that.
Awesome. Any other questions or comments? Even just giving an example from your local place, that would be great as I transition to the next more technical talk.
Hello. So, no, please, my concern is sometimes with the EMR system, when the challenge can be the network connectivity issues.
Yes.
Sometimes when you're entering data and then you lose your connectivity, it makes it difficult to continue. So sometimes you have to transit to the paper system and then later on come back to transfer most of the data back onto the EMR. And sometimes when that happens, you lose track because there's a discontinuity in the filling of the information onto the EMR. I don't know if you get what I'm trying to say.
Yes.
Yeah, so sometimes it makes it sometimes very cumbersome going front and back and forth to get the information continuous.
So now this is a big problem, right? Of years of working in informatics remains a big problem. So a few things. One is that the technology has changed, okay? And the reason why the technology has changed, the mobile phone, my first mobile phone was a Nokia, was it Nokia 10,000 or something like that? And it was, that phone, you could, you would lose data. I mean, it kept power for a week, but you would absolutely lose data. And what is different, the phones that we have today are really small computers in our phones. And they completely changed if you think about local storage and local access. And so the way people have done this is to really disseminate some form of browser-based data collection. And why that is important is because you can, I don't know if you've used Chrome and you're traveling without internet, you can still work on Chrome, like on your paper or something like that, till you get internet. And because you're able to sync the data in that form. And so the reason why the technology has improved and the browser technology has improved, the reason why that's not applied today in like your use case is that it would take a lot to overhaul the old architecture and the old system to allow for something small like this. And the way, if you're using a mobile phone, you put a cache of patients, right? You can put that cache. Now, if you're not in an emergency situation, so you're going to a clinic, you already know the patients who are coming, then what you have to do in that case is that you can pre-download the patients that you know you're expecting. And so in that situation, then you have to implement a scheduling program that is effective. Even if you have to browse, Judy came and was not supposed to come, then if you have to prefetch that type of data, then it's a small amount that is required. People deployed their own networks. I think this was very expensive and tough. Now, maybe as we see people like Elon Musk bringing their own satellite, that may be feasible at some point, but that was not sustainable. That has not been sustainable in the years that I've been doing this. And but it's really modernizing the application, but people feel, how am I going to develop all this? And then the synchronization can be problematic because of the way the sync modules are deployed. Does that make sense?
Yes, Doc, that makes sense. Thank you.
Carrie, you had your hand up?
Hello, Prof. Can you hear me, ma'am?
Huh?
Can you hear me?
Yes.
All right. I thank you for your presentation. I wanted to ask, apart from OpenMRS, how is it different from databases like the RedCap, databases like Survey CTO? Is OpenMRS strictly for hospital data, or can we also use it for research, trials, and other purposes that are not strictly the hospital for the hospital? And is OpenMRS, is it free? Can one get it for a private hospital, set it up for a private hospital?
Okay, great question. So in the ideal world, right, research would be embedded with the clinical system that is used, okay? And why that would be important is that you get more access to data. And so if you are, let's say, looking at death from COVID patients, right, that you cannot really collect that data differently. And so what you would be doing is that you'd be extracting the data sets that you have and then run those same data sets into RedCap, right? So you can do RedCap modules, right? And RedCap has been successful one because it's easy to create forms for data collection when you're doing primary data collection that is outside the clinic. So if you have a survey or you're following patients because you want to collect different types of data. But ideally, what you should be doing is using something standardized and then providing an API that allows people to query the data set and then amalgamate it, and then they can push it to the other database that they want. And that's the example that I showed for Odyssey, which is this OMOP dictionary that relies that you have your baseline, right, of your electronic medical record, but then you can now analyze it in a batch, in a population level. And some of the factors, but I'm not tied to OpenMRI, so you can use really any EMR, but you have to understand the structure. Is it records done by visits? Are they done by encounters? Those small things that allow you to be able to extract the data. And then is the data, does it use a standardized reference terminology, and does it expose things in a standardized terminology? Okay. I don't know where my talk is.
Yes, ma'am. I also asked if you can set it up for a private hospital. Is OpenMRS something I can get personally and probably use in a private setting?
Oh, yeah, if you just want like data collection, but it's very difficult to get data out. That's one of the limitations of the system. Yeah.
Why is it that way?
Because of the data dictionary. Okay. The data dictionary. So the thing that allows you to make it easy and customizable makes it very difficult to report against. And so you have to be, it uses terminology, but because you have this table that is just observations that you keep moving. And so sometimes people struggle with the data extraction. And that's one of the areas that people struggle with. Any other comments, questions? Many ways of being an informatician, right? So I work as a radiologist, I read studies, I do AI research, and that's essentially it. So this talk is really done with me and a colleague of mine, Dr. Colley, who's one of my mentors, and he works at UCSF. And so I just want to make sure he gets credit for it. And then, okay, so if you had multiple resources, right, all the resources in the world, then you would have something called an interface engine, okay? And this is your master that you understand very well. And it would interact with all these systems. We've talked a little bit about EMR. As a radiologist, usually I will use a dictation to dictate my reports. Some people write them. I talked about a health information exchange. You know, I told you that my fellowship training program required for me to work on a notifiable condition detector, so it would get labs from all labs in the state and then come with them and put them all here. So this may need to send some information. And imaging is done with special cameras like an ultrasound, so like this one here, and you store the images in a system called PACS. But to manage the workflow, then you use something called a radiology information system, and you can also have a lab information system. So let's image elephant Rex, who's not feeling well, has right upper quadrant pain. And so in their care, this at least here you have an order, and you have this type of orders even in Kenya. And this is because sometimes they're only paper-based, and you're just saying, why do you want this study? But in the electronic medical record system, you can have an order system. And that's important, which is why some of the incentives were being given to provide orders, order support and meaningful use, is to make sure that you can see when something inappropriate is ordered. For example, if you have a child who's having an order for a CT scan for abdominal pain, you could say, well, you're exposing this child to radiation, maybe you should consider an ultrasound. So these orders allow you to, they communicate an intent, but managing orders and understanding the order entry system, and especially their role in, because they're so important for the clinical decision support and alerts. For example, when you order a medication that I'm allergic to, then the order can say, look, Judy's allergic to this. And so you can see how the interaction of clinical decision support comes working at the same time with communicating intent with orders. And you do lose that information when you are using a paper-based system. So here in the US, Rex would come to the hospital and come to the radiology department and be seen, at the registration desk, right? So this is not unusual to see, and they would have their demographics, a medical record number, and insurance information entered, right? And then this information will be entered in the EMR. The reason why I want to show you this imaging is that there's an important thing. So you've had something called REDCap. I talked about some terminologies like ICD code, SNOMED, LOINC, RADLEX, all those terminologies. But now I'm bringing another standard here called HL7. HL7 is so important. Now, you, again, may not really program the HL7 messages, but you should be familiar with it. And so you register, you say Elephant Rex is here, they're registered in the EMR, they get this message, which is, the type is called ADT, which is just an admission, discharge, and transfer message. And it comes to the interface engine, who sends all these messages all over to all the downstream system. This is an example. Primarily, this HL7 messages. So there's an organization called HL7. You should look it up. So I showed you Odyssey community. I showed you the H3 Africa community and HL7 community, depending on your interests, really. And if you're interested more in public health informatics, CDC, in fact, has a public health fellowship that is open to people from, developing countries to participate in at the CDC here in Atlanta. And so, you should just have open-mindedness about what's possible. And so if, this one, you can see that it has the address of the patient, what the system is. So it just gives you the things about the system, and that this field. I'm not going to spend time going into the segments of the messages, but with the HL7 messages, so is what allows you to use another database without manually entering the data that usually happens. And these are some of the fields that you can fill in. But once the RX is registered, they come to the check-in point. And remember, they came in for a right upper quadrant ultrasound. And when they come in to check in, so this is taken up by the workforce. In radiology, it's called a radiology information system. In lab, it would be a lab information system. And in pharmacy, they would have their own system. And remember this, the initial recording generated, the demographics of the patient. But this other data is now provided by the radiology information system. And now it gets an ORM message. And so this succession number maybe says an ultrasound, this is random, it's unique to the patient, an ultrasound. And so this message now is coming from the RIS and then going to the relevant systems. In this case, a database of critical results, a database of imaging archival, and a voice recognition. Here's an example. It's just XML. You have to be very strict about it, and every institution implements it in different ways. So if you come back, you acquire the images now. So you put REX here in the scanner, you get images. The thing that allows people to communicate these two is something called a modality worklist. And what you want is to avoid people entering data again here when they come in to pull an ultrasound, right? That's why I said, if you had to pick one thing that you'd have to fix, would be the registration system, that it's more centralized. And then you have to figure out, how does your registration information get to the other systems? And this is an interface engine. So there's an open source one you can play around with if you're very, very interested in trying this out. It's called MIRTH, M-I-R-T. And you come back here and that information comes to these two devices, and it's the modality worklist, and it knows the information from the RIS that says, well, REX is here and needs a right upper quadrant ultrasound. So these HL7 messages have been in two versions. The first one was 2 point something. These are mainly sort of this type of messages. They're separated by pipes, very, very strict. There was one that was developed 3.0. Unfortunately, this was not very well adopted. You can see this is an XML format for the people who know it. But it's a messy, there's quite a lot of things that you have to record in every encounter. And so the future for this, and if you're going to think about a standard that you have to learn about, then you have to look up this thing called FHIR. And the reason why I emphasize on FHIR as something, there's a great community. If you just search this online, a lot of free education resources, is that if you think about FHIR and you are working with a system or you are working with a developer, if they start off with this RESTful API, right, then you have an endpoint that shows patients' data are recorded as blah, 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 blah. It's going to make all your downstream tasks easier, and you don't have to worry about maintaining XML or other different types of format of data. So this is a dashboard that you'd see, for example, on an ultrasound. You can see different studies, and this is a modality worklist. You'd have to select where elephant REX is, and then you'd start to scan. This is an ultrasound. You'd scan the elephant, and then when you're done, you'd end the study. So in medical images, so these are some of the images that you acquire, and you'd send the images, but imaging is managed by a standard called DICOM, right? I'm throwing a lot of new words to you. Remember, I said that this course takes a whole semester to teach, and I just want to give you a sense and also a grounding that allows you to understand where you are and what you need, what are the skills that you require to get to the next level. And so DICOM is one of the most mature standards because it makes sure that, that if you just have this screen, you don't need to, you can see that you have the option to enter the data, but if you've made a modality worklist that it can read the information, and it works for all cameras that work in radiology. And it's not only just a data standard that talks about storage, but also talks about transport and how data are shared across modalities. I have never read the whole standard, which tells you that it's really complex. I just picked the things that I need. Now, if you take a picture like this and you look at your metadata, so if you pick your phone and you look at your metadata, it collects a lot of information about you. You know, it collects where you are, what camera type you are in. And in imaging, it turns out that it's the same thing. If you have this DICOM metadata, and this is important for you to know, because if you don't anonymize it, you could leak a lot of information to patient about patient information when you share your data. So you have this metadata also provides a richness of data that is very important for us when we build AI algorithms. And so if you look at these ways, if you're very neurotic about how you organize your pictures, you start by year, then you go by month, then you put the exact picture. And it turns out in imaging is the same. You start with a patient, Rex, who got a study, ultrasound, and the study could have different views or different series. So for example, if it's a CT scan, could have an axial view and a sagittal view, and every image in that data is an instance. So you understanding the standard, so this is something very familiar to me, and this is because I work in medical imaging. And so, you know, I showed you that Rex was getting some ultrasounds, get image, and then pushes them to the PACS, which is the data set. But you need to notify all these other systems that, well, we're ready and we now have images. And so this again sends an ORM message that shows that the study has been completed, if there was contrast that was used, who was the performing technologies, and if there was a technology comment. And so that message now, remember, you know, the first one came from the RIS, but now comes to these other systems that tells you that you're ready. This is Dr. Coley, who I credited with this talk. And you can see here, he's dictating. This is just a voice thing that allows you to just quickly dictate the report. And once you have that voice recognition, you know, this is the information that goes there. Remember, we started with an ADT message and then ORM message, and now you have an ORU message, which now allows you to go from the voice dictation back to the RIS. This is the workforce that just ties the glues together. And then from the RIS, you're going to have a message that says, hey, I have a report, that sends it out to everyone. And this is HL7 message. So if you focus on this, you'll see that it's been, you know, it's saying, look, the liver is normal, the patient, you know, the right kidney is normal and hyperechoic, but the impression here is gallstones without acute cholecystitis. So if you have the access to the interface engine, you can intercept these messages. And this is how, for example, if you had a good orchestration, the question that I had to answer for how do you manage you know, synchronization that didn't work, you would be tracking the messages and you'd see what messages have failed if your system is deployed. So Rex leaves the radiology department and goes home. And so, like I mentioned, today we have this FHIR standard, and now most of us are moving to this DICOM web, and it just allows you to use, this is a little more technical, it allows you to use this type of terminologies for the DICOM web to be able to fetch information you need. And this is some of the examples of the FHIR resources that are available. You can see that they can describe individuals, they can describe medication, they can describe allergies, they can describe patient management, which are encounters, they can describe appointments. This is a communication standard. But if you had to document what's happening to the patient, then you would have to require like a standard like the OCL one, the CL one that I showed you, or WHO for diagnosis, ICD codes, or a different standard, SNOMED for just the terminologies. And so I wanted to show you this to help you just see, okay, you know, you know nothing about this, how do standards fit in, and how can you use it for you know, use it in your work to understand sort of like your role and how some of this information flows. I see some questions about this open source medical record system. So if there are none, I will spend like 2 minutes to walk you through how like records are stored, if that's okay. And then I'm going to end my talk. So here is an example of deployment that we made about a project that I work on, which is called LibreHealth. It's a more simplified version of the OpenMRS system, and I just want to show you how I can log in. Oh, I see what's happening. Where I should be. So you logged in here. Right. So some of the things, if you work in different hospitals, you'd have to be able to provide people information that they about where they're logging in the first place. And because you want to make sure, so it's this context availability of your site, and that's important for you to understand. So that's your home. And then you come and search for a patient, right? I talked a lot about patient management and how they are registered. So you can also register a patient, if you estimate, right? So in this process of registration, when you build system, you have to make sure that even if I'm creating a person, and I talked a lot about some of the things that you have to consider, that you search for them before you create. In the backend, that's what's happening, because you want to make sure that that you are creating, you're not duplicating records, else you have to go back and manage them. And so you can see that you can have an identifier, whatever you want. So this is bad, right? Because you should be generating an identifier and then save your patient. And now you can see that you have a patient chart that is open. So most records now, for example, let's say there's a wellness program, you'd enroll the patient. And so there's a lot of work that goes on in the administration section that allows you to manage some of this, like manage new doctors when you have new ones, manage types of visits, manage a facility. Let's say you've added more places, and you can view your concepts and you can manage your forms if you need to. So, and then you remember I talked about this HL7 messages. So these are very, very old flavor of OpenMRS. And so you can have a visit, and you can see, you can add a visit. This is what we'd be doing as a doctor, or you can review the demographics of the patient. You can add more things about the patient that you want. You can add some graphs if you want, and you can enter your forms. And we were just doing some work in radiology. That's why this is here. And so if you come to the forms here, so you can duplicate simple forms. And this is why I say that this was very, very good allows you to create, this is pretty much like very vanilla OpenMRS type of thing. And you can create new forms easily, but that comes at the cost that it's very difficult to analyze records. And so if you remember, we kept searching for a concept like cough, so you have to make sure that you load the appropriate dictionary. Sometimes it doesn't come that way. Maybe just extra. Yeah, I guess this dictionary is empty, but then you would then enter the data. And so as you come in to take care of patients, this is how you work in. So, the parent OpenMRS system is very, very detailed, and this has evolved really because of how different systems are, developed. So for example, you can see that these are, you can see that you're selecting the location for your session. For example, if you're a pharmacy, if you're an outpatient. So, okay, I showed you a very, very simple way of looking at, can you see my screen now?
Yes, now we can see even your mouse.
Yeah, okay. So I moved in very, very simple, and so here's just a flavor of a deployment of the same system, but very simple user interface. And I said you can start off by creating a patient here. So I created a patient called Simba, and you would create them here and add them, and you can see sort of like most people will have a visit and do all those things. So this is mainly like an outpatient type of system, because if you have inpatients, then you need to have more information. Then I showed the dictionary and sort of like all the tabs and how to navigate, including the administration that allows you to like resolve your messages, errors, you know, allows you to look at your concepts, allows you to add providers and new people and new visits and new users or new locations, which would be the job that you have as an informatics officer. So then I went on to this more advanced system, and I don't know why it's in French. And I said, you know, you could select, this is like a same system, but a different user interface built on it. And you can see, so when I teach this course for my students, I have them go through every, like do tasks, create tasks, investigate, find errors, fix them as part of this course, because that's your business if you're in the sort of health informatics business in the hospital. And you can see you can change your location, right? Because you have many locations. And then you can, for example, search for a patient. And here you can say, oh, you know, I'm going to search for this patient. And now, I don't know why it really is in here, but you can see what you can observe. You can see the summary, you can see the weights, you can see the upcoming appointments. So this one doesn't have enough people, and you can see the patient here. So you're able to add, I don't know why it's in French. You know, you're able to add like the details that you would be required that are part of patient care. Let me see if I can load this on Chrome, which allows us to do automatic translation. So I was just showing you sort of like how, if you're thinking about an EMR, how to navigate it. So this is. And maybe isolation mode and login and. Yeah, so you can see that it shows what are my diagnoses, my vital signs, appointment, and I can put, you know, an appointment and change whatever I need. And so this thing that, you know, that I have my students walk through this, especially when I teach informatics students without clinical experience. And so you can see that I can add patient, I can admit the patient, I can record vital signs. Here, for example, I could say maybe my pulse rate is 56 and my blood pressure, if I say 456, you know, then it has these rules that help me know that that's probably not possible that patient would not be alive, to try and curate the data set. And so then I can, you know, confirm and, you know, register the patient. And now you can see that all of a sudden that they have some vital signs. So when you go back to their health care, you can see that this is their rate and you can see their vital signs. So most people will organize this in terms of a visit or encounters, and that's what will happen. And you can see that I can add allergies, and all these things are being driven really by terminologies that are underlying to the patient. And when I put in an allergy, then if I come in to look at the patient and order, okay, now it's decided to go back to French. But if I come in and look at the patients to order, you know, their medication, and I order an allergy, you know, medication, then it's going to say, no, you're going to cause trouble to the patient. So this is sort of end to end if you look at people who work with clinical informatics. And that's the end of my talk. Well, I hope that you learned something. Kevin, maybe you can delete that part of my screen that's frozen, that's just showing this, one part. And I hope that at the end of this, you have some questions to understand how to localize, or what would be the role of informatics for you, so that when there is more training available, you'll be able to get started or figure out how to get help in order to save patients' lives, whether in research or public health or pharmacy or in the hospital. Okay. Okay. Since there's no one saying anything, I'm going to assume everything is okay. Kevin, I'm gonna leave now. Bye.